Good morning. Thank you for inviting me to speak about this. I also am not a robotic hernia surgeon, and I may also bring a little bit more rain to the parade. It's not my intention, and this is not to bias either way as far as whether to use it. But my role is I'm a hepatobiliary surgeon at the Cleveland Clinic. I'm also chair of surgical operations. So in my role, I have to oversee the costs and scheduling and some of the quality aspects of our 225 ORs in our system. So I'm just going to talk through how to do a technology assessment, and in terms of robotics specifically for hernia, you can apply this really to any technology, not just robotics. And really, I think this has been the challenge for me in my administrative roles, that a lot of the technology is brought forward by information that's been supplied by the vendors, and I think was really excellent, was really presented very clearly in the last presentations, that we have to really look at our outcomes as a group and make very important decisions regarding this very expensive technology before we go forward, and really not just trust what the vendors give us. So the way we do tech assessments at the Cleveland Clinic, of course, just like all of your organizations, quality is the most important thing. So we definitely will not choose a less expensive option if it reduces the quality, because of course it affects the value. And cost effectiveness and quality are not mutually exclusive goals. We are the gatekeepers. So we have to understand, unlike the quality collaborative stuff, we are comparing ourselves against individuals as hospitals. So in your region, your market and network service folks, especially in areas like hernias, which are just like cardiac surgery, joint surgery, and others, they're really being commoditized. So your market and network service folks are going out to employers, to insurance companies, and try to market your services to get these narrow network and contracts. And a lot of that is based on quality and cost. So if your quality is great, and overall, because of length of stay or something else, it actually drives down the cost, and that's great. But if your quality is equivalent and your costs are more, you're going to have trouble competing in your market. So what makes up the cost? I think this is really important because it's really, you really need to sit down with your administrators, your folks who run the operating rooms, and figure out what your actual costs are per case. I get residents who are presenting papers for all different kind of specialties, and they come and say, hey, can you calculate my cost per case? And it's really interesting to see how they've come up with it. Remember, it's not charges, it's costs. The direct costs are mainly supplies, implants, drugs, your nursing and anesthesia, your support services such as transport, your what it costs to sterilize things. And then your indirect, so if you're in a facility that's building a new medical school or building a new hospital or adding on, your indirect costs for your entire organization are high. So that may affect your indirect costs and your ability to, on your cost per case. So the other thing that you have to understand is, it's not just about the cost, it's about the revenue, okay? So this is where if you go to a dinner talk and somebody gives you a presentation where they found that in their practice, robotic blank is the most profitable thing in the world, that may not at all apply to your practice. It really could have a completely different outcome in your payer mix. So you really need to understand how that surgeon is charging. So for example, if your payer mix is still such that it's a commercial payer with the percentage charges, and you charge more, what happens to your reimbursement? Anybody? Goes up, right? So in a situation where you add charges to your case, if you have a model where you have a payer mix that pays more, of course robotics will actually generate more revenue because you're charging more, and they're actually reimbursing as a percentage charges instead of the bundled. But if you have a high government payer, they don't do that. So you have to really understand. I'll go through a couple cases here in a minute of how we do it. The case mix of the operating room and the bundled payment versus the percentage charges or per diem. So you have to really sit down and know what your payer mix is. It's also what your baseline cost is too. So I can tell you, I ran the costs for our group, and I have to give kudos to our hernia group, which their costs are so low for laparoscopic hernia repair, Ajita and her partners. It's almost impossible that anything else you do wouldn't add cost to it. Unless you start weaving your own mesh in your garage, there's pretty much nothing they can do to drive their costs down. Our supply chain has done a great job of lowering our costs per case for trocars, for mesh. Anything else is going to cost more. So their bar for something to be better is set really, really high. So the other thing that we have to look at is the more expensive devices that save time pay for themselves. Really, this is a very, very flawed myth. Most of the operating revenue you get is on opportunity revenue. So if you finish a case, if you were going to do 5 cases, and because of that, and you save so much time on the first 5 that you do a 6th, then that 6th case was that was where the time actually helped. If you're actually just lowering your operative time and you have a fixed staffing model, those staff get paid for the full day no matter what. So if you finish at noon and they sit drinking coffee from noon to 5, that actually didn't lower the cost per case. And the fact that surgeons have a little impact on OR costs, we do. We absolutely do. And then the sales reps should never actually know what devices really cost. Most of you are involved in GPOs. Part of that GPO process is your sales prices are confidential. So your vendor may be only telling you the price retail versus what you're currently using retail. So please check with your supply chain before going to someone and saying, hey, this is cheaper. So I'm going to go quickly to the case here. So we're going to go through the how we evaluated robotics, a robotic procedure at the Cleveland Clinic. I blinded the CPT codes. These are not actual CPT codes, and these are not actually the actual dollar amounts, but they're all directionally accurate. So let's look at our market data. A big draw to the robot was that we were going to get more cases brought in, because if you put the robot in, we're going to have this entirely new market. And that's been sold really aggressively by the vendors, that if you have it, you're going to get all these patients in that you never would have had before. So we started. We looked at our market. So we have 21 counties that we will mainly see from the Cleveland Clinic. And if you can see, the reality is, because of the complexity of the stuff we were doing, we actually had the non-robotic cases actually were the ones that had the bigger draw. It makes sense. Most patients that were coming to you from somewhere else were coming for you. And it was the complexity of the cases that you do. Whether you use the robot or not, they were coming because another surgeon sent them to you. And that was seen in our data. So a lot of the international, with one exception, which was mitral valve. Then we looked at a per case financial, okay? So we looked at our contribution margin, and we did robotic versus non-robotic. So the reality is, the robotic, as you all know, is probably a little more expensive, which negatively impacts our contribution margin. You see that, a $7,000, $8,000. So what we looked at, and we also looked at OR time. So again, not a huge difference. Again, this was a single CPT code. I will tell you this wasn't hernia. We don't have enough of an end exactly to do that, so this was in general, but you can do this for any CPT code. So we looked at our OR time to look if there was any difference between that based on the volume. This is my favorite slide. This is where I challenge all of you to go back to your administrators and get your own payer mix, because this is really the key to how to keep your hospital financially viable. If you looked at your per case between the commercial and non-commercial, between the robotic and the non-robotic, you can see the net income for the non-robotic cases was higher, and that's because there's the cost. Not a big deal. You say, okay, so what? I lose a little bit more money. Again, commercial payers. Look at Medicare. So when you look at your Medicare mix, most of you may be losing money on your patient to start with. It's just how much more you're going to lose. So this is what really drives, this is the information that I challenge you guys to go back to each one of your administrators and get this analysis done. Because this is the difference between, having a financially viable and non-viable program. So then we started looking at the single surgeon analysis, because in this, the individual matters. A lot of times what happens is the more senior surgeon in the group may not be using the robot, but they also may have the better payer mix. The junior surgeons may be saying, hey, I want to try robotics, this is a new thing that I want, it's going to be really, but when you look at their payer mix, they may be seeing they actually may be the least amount of commercial, okay? So we looked at a single surgeon analysis. Again, if you looked at this for commercial and then Medicare. So he went from breaking even to a big loss when you switch the payers. And again, this really makes a difference. You know, we are in you know, Northeast Ohio. About 85–90% of our patients are from Ohio, and our payer mix, we have to be a little bit more careful with how we evaluate new technology. So we are very. I have a very difficult job because I say no to a lot of my partners, and I feel really bad about it. But at the end, you know, when we're dealing with 200,000 cases a year over our system, a small loss on each one is huge. So we basically look at, we've created up an algorithm, we've just written it up for a manuscript. It's a mathematical algorithm to look at how we allocate robotics resources. So we figure out if it's a standard of care innovation. Now this is a little subjective and this is hospital dependent, but for example, if the more than 90% of the cases in your hospital are done with the robot, for example, the prostate, we would say that's standard of care at our hospital. That's not really considered innovation. You would need that to continue the practice. We look at our market data. How many of those patients are from outside of our market? And then we look at the contribution margin relative to other techniques. So we'll take the same CPT code if it's done laparoscopically or robotically, compare it. And then we do look at length of stay. Great point. If you can reduce the length of stay by a day, it may completely, when you're negotiating with payers, negate the operative costs completely if you can actually reduce the length of stay. So this was a sample. So in our hospital, urology, cardiothoracic surgery. So for example, I get criticized that we have a low utilized robotic robot in the cardiac space. But in our setting, I think about 10 cases a year pay for that robot. The difference in and you have to know this, you have to realize that the difference in reimbursement for something like a robotic mitral valve versus an inguinal hernia or a colon will actually be able to drive that program from negative to positive. So this is at the Cleveland Clinic. You see these are our top 10 cases. This tells me that if our case mix is primarily this, we have a viable program. Any excess time we can dedicate to innovation. So if our robots are 70% utilized with this stuff, you can use the other 30% to do whatever you want. If these top 10 procedures start falling off the rankings, we're actually going to start going under as far as that cost per robot. When you look at capital, you look at maintenance, you look at the supplies, so it would actually end up being, we would show at the end a negative for the robotics program. This is how we keep our robotics program financially viable. And we use this every year when I go to capital to decide whether we're going to buy another robot to add to the fleet. So the take-homes. I can't stress to you enough, the financial viability, this is secret stuff I'm telling you right now. Guess what? If you do this, your market and network service people will love you because they can go and compete with you, compete with the hospital across the street that says that, hey, our programs are this cost and I'd like to market you as a center of excellence or whatever because you figured out a way to make this profitable. And you really need to know multiple variables when you're putting creating a new program. It's really not just the supplies or length of stay. You really have to look at it as a whole. So really, again, I encourage you to work closely with your administrators. I have great administrative partners that I value tremendously at the Cleveland Clinic, and they have taught me more about this in the last couple of years of my role than you could ever learn it, you know, just by taking a course or an MBA or anything. So, you know, please, I encourage you guys to know your market and know your own practice very well. Thank you.